This is the first session of the World Day of the Critical Lung. My name is Manuel Garay from Colombia, and I'm going to introduce the first session of the day. The name of this session is The Lung Under Extreme Conditions, and the first lecture of the day is the effect of high altitude in mechanical ventilated patients by Dr. Guillermo Ortiz from Bogota, Colombia. He is the official representative of the Latin American Network for Research in High Altitude, RELAMI. The second lecture is ultrasound in massive pulmonary embolism by Dr. Jesus Alvarez from Spain. The third lecture is the New Horizons in Pulmonary Arterial Hypertension Therapies by Dr. Victor Morales from US. And finally, the last lecture of the first session is the Tuberculosis in Intensive Care Unit by Dr. Mervyn Merry. And finally, we close this session with questions and answers for our speakers. It's a real pleasure and honor to introduce to you the first lecture of the day by my professor, Dr. Guillermo Ortiz from Bogota, Colombia. He is a pulmonary physician and critical care physician here in Bogota, and is the official representative of RELAMI, the network of research in high altitude. And his lecture is the effect of high altitude in mechanical ventilated patients. Welcome, Dr. Guillermo Ortiz.
Thank you, Manuel. Paulo, I would like to double check. Can you hear me properly?
Yes.
Okay, so first I would like to say that it's a pleasure to me as a part of the organizing committee to start the first version of the World Day of Critical Care Lung. Today I'm going to talk about the high altitude effects of mechanical ventilated patients. I don't have any conflict of interest for this presentation. This is going to be my agenda. First of all, I'm going to speak something about hypobaric hypoxia and the effects of chronic exposure to high altitude. And then I'm going to go over our research project. As a background, it's estimated that about 140 million people live at altitudes about 2,500 sea level in many parts of the world. 80 of these people live in Asia and 35 million live in South America. As the barometric pressure falls at the height of sea level increases, the inspiratory fraction of oxygen remains constant, so as the barometric pressure decreases, the partial pressure of oxygen decreases proportionally, which is called hypobaric hypoxia. Look at this map. In this map, we can see the Andean region, which about 35 million of people live in high altitude. About 5 billion of those people even live at higher altitude than 3,000 and 3,500 meters above sea level. In this graph, we can see the partial pressure of oxygen in people residing in high altitude comparison with sea level. Sea level, the PaO2 is about 100. In cities, for example, as La Paz, Bolivia, we can see here that the PaO2 can be as low as 50%, 50 milligrams of mercury. Here in Bogota, we live 2,500 meters above sea level. Our PaO2 is about 60 millimeters of mercury. People that have been exposed to altitude for a long time can have an adaptation process. Adaptation to high altitude describe changes that have occurred over a number of generations as a result of natural selection in hypobaric hypoxic environment. These features that increase endurance to chronic hypobaric hypoxia could be useful in hypoxemic diseases such as COPD, myocardial ischemia, or even acute respiratory distress syndrome. It is well known that this adaptation at high altitude brings about physiological changes. We can see different changes in pulmonary volumes, pulmonary circulation, and even composition on blood. But the impact of these changes is supposed to be very relevant. Now it's currently unknown since clinical studies have to carry out clinical studies focusing on this group of individuals. We can see here a recent released paper about the physiological effects of chronic hypoxia or hypoxemia. In this graph, we can see that many of those changes are mediated by a transcription factor called hypoxia-inducible factor, which is a dimer with subunit alpha and subunit beta. During normoxic condition, a proteolytic process takes place in the cytoplasm. During hypoxic condition, this transcription factor does not undergo some kind of proteolysis. It translocates to the nucleus, it binds to the subunit beta, and both of them can stimulate these sons of genetic factors. And look, on the next slide, we can see the broad spectrum of physiological responses to these transcription factors. Look, glycolysis, can be control of ventilation, lung development, and even lung injury. Besides these physiopathological aspects, we think that there are genetic background in those changes of adaptation. If we compare people from different areas of the world, here, for example, Andean people, with people from Asia, Sherpas, we can see that these people develop less pulmonary hypertension in the adaptation process. So it's a very variable adaptation process all over the world. On behalf of the American Network of Research of High Altitude Relami, I'm going to present the International Study Assessment of High Altitude over ERDS and mortality risk in invasive mechanical ventilated patients. Our research question was the effect of altitude in patients on high altitude on sea level, recurrent acute respiratory failure, and recurrent mechanical ventilation. Our hypothesis was that the outcome of acute respiratory failure, recurrent invasive mechanical ventilation, is influenced by the altitude above sea level. In order to test this hypothesis, we performed, first of all, a systematic review of the literature, and secondly, an observational study in order to test this hypothesis. This is the first part of our systematic review. As you can see, we searched in 3 databases, Medline, Embase, and BBS, in order to answer our questions. In the first step, we got 293 studies. We excluded 266 just because of the title, not relevant to the questions. Then reanalyzed 27 studies. After reanalyzing those studies, we had 0 studies to answer our questions. So it means that there is a lack of information about the high altitude and chronic mechanical ventilation. So talking about observational study, the objective of our study was to describe the outcome of patients with acute respiratory failure undergoing invasive mechanical ventilation according to the altitude above sea level. We had, for that observational study, 3 outcomes. The first was mortality and intensive care and hospital discharge. The second was the proportion of patients with ERDS. And the third one was the days of mechanical ventilation and intensive care unit stay. What was the design of the paper? It was prospective, observational, multi-center, international, most of those countries from South America and Spain and Europe, a cohort study. Our inclusion criteria, patients with ages between 18 and 90 years old during the month of August 2016. Those patients were living during 40 years before intensive care unit admission and the same attitude, and received invasive mechanical ventilation for at least 12 hours. What about the exclusion criteria? Home oxygen therapy, diagnosis of metastatic cancer, pregnancy, or absence of informed consent. About the protocol, we designed a website to register demographic characteristics of the patients, comorbidities, admissions. If information was recorded until death, in 30K unit of discharge or 28-day mortality, whichever came first. Day 0 in order to identify the incubation time, and the PF2 ratio was adjusted with the formula that you can see in the slide. For the statistical analysis, continuous variable were expressed as compared method unit test, and category variable were expressed as proportions. A priori, we define 4 levels of altitude: low altitude, lower than 1,500 meters above sea level, and very high altitude, more than 3,500 meters above sea level, 2 categories between them define an intermediate altitude and high altitude. About ethics, Ethics Committee of Universidad del Bosque, Bogotá, Colombia approved this study and when required by the Institutional Review Board at the individual sites. What about the results? Regarding the results, we have initially 44 intensive care unit registers, but after exclusion of 7 sites, we have 31 intensive care units of 7 countries. 6 countries in South America and 1 country in Europe and Spain. At the end, we had 280 patients considered from the final analysis. About physiopathological changes in this table, you can see how PF2 ratio decreases in low levels, from low levels to very high altitude. That's what we expected. And the level of hemoglobin is higher in very high altitude, which it means that maybe most of those patients were adapted to the high altitude. About the comorbidities, the most important comorbidity that we had was COPD, diabetes, chronic heart failure, and chronic renal failure. Maybe the most important thing is that diabetes decreased the incidence of the prevalence in the high altitude. Look at this. There is a decreases the presence of diabetes from low levels to the very high levels of altitude. Talking about mechanical ventilation settings and parameters, maybe there are not many differences between arterial volume, peak pressure, the level of PEEP, respiratory rate. We found that the plateau pressure were higher in patients in high altitude in comparison with patients in the other altitude with a P statistical significance. And regarding the clinical outcome, we didn't find any difference in terms of mortality in the different categories of altitude. So it looks like the altitude does not influence the mortality in patients on mechanical ventilation in different levels of altitude above sea level. We can see here that the presence of ERDS was higher in patients in a very high altitude. About the discussion, we can say that the increase in the altitude above sea levels does not influence the risk of mortality of invasive mechanical ventilation. The altitude above sea levels is associated with several physiopathological changes, and there is a lack of information about mechanical ventilation in patients who live in high altitude. About limitation, we can say that it was an observational study. Inclusion criteria allowed to assure that all patients were acclimatized, but we are not sure if we're adapted to high altitude above sea level. Adaptation could differ between races, and we didn't have that analysis. The number of patients in extreme altitude was very low, and long-term outcome was not considered. Regarding conclusion, we can say that the knowledge of high altitude on patients with acute respiratory failure that require ventilation is very scarce. In this prior study, the increase in the altitude above sea level is associated with several physiopathological changes. However, these alterations do not influence the risk of mortality. It's possible that the subgroup of extremely high altitude patients have different features that could not be detected by the low power of the study. future studies are required to address this possibility. Thank you very much, and I'll be happy to answer any question during discussions.
Thank you, Dr. Ortiz, for your interesting lecture. The second lecture of the first session is the ultrasound in massive pulmonary embolism by Dr. Jesus Alvarez from Spain. Dr. Alvarez is a professor in the University Hospital from Getafe, and he is director of the Master of Ultrasound in Emergency and Critical Care. Welcome, Dr. Alvarez, for this session.
Para saludar a través de Skype, simplemente saludos y vamos a
connected to
a ver si
this
desarrollamos
room
esto rápido
through
y
Skype. I'm gonna be brief. I hope this will be straightforward.
Agradezco a la organización por estar
So
aquí en este evento
I'd
tan
like to thank the
interesante para hablar, además, de
organization
un
for
tema tan
inviting
de
me
actualidad como es
to talk about
la
this very
ecografía
interesting
en el
and
embolismo pulmonar
hot
masivo.
topic, ultrasound in
Hace
massive
20 años
pulmonary
empecé a dedicarme
embolism.
a este
I
campo
started to work
y
on this
entonces éramos
topic
muy
20
pocos
years
los que nos
ago.
dedicábamos a ello.
There was only
Y a
a
esos
few of
pocos, cuando
us
nos
who
invitaban a
devoted our
algo,
time to
íbamos,
this
contábamos
topic.
cuatro cosas y todo el mundo
So
quedaba encantado.
everywhere we
Afortunadamente, esto ha
went,
cambiado mucho. Hoy en día el conocimiento de la
talked about
ecografía
what we
a nivel
knew
mundial,
and everybody
a nivel
was happy.
se ha incrementado
But the situation has
notablemente,
changed
pero reconozco
because
que a
now
mí me ha
many
quedado
doctors are
el
aware
hábito de contar cuatro
of
cosas.
this
Las cuatro cosas que
new
les quiero contar
technique
hoy
or this
es
technique.
que
But I still
utilidad
have the
puede
habit
tener
of
la ecografía en la
talking
evaluación
about
diagnóstica de un embolismo pulmonar.
very few
¿Qué
and
utilidad puede tener
precise
la
things.
ecografía en la
The use
evaluación
of
clínica
ultrasounds
de un
in massive
tromboembolismo
pulmonary
pulmonar?
embolism
¿Qué
and for the
significado, qué
diagnosis,
calidad y qué seguridad
the
tiene
significance, the
la que estamos
quality,
practicando
and
hoy
the
en día,
safety of this
focalizada,
technique,
orientada, hecha por
focused
clínicos con respecto a la ecografía
and
arreglada practicada por cardiólogos
on
expertos
this
qué utilidad puede
type
tener
of
lo que llamamos hoy
diseases
la
and how
ecografía
it is
clínica en
different from
español
the
y la ecografía en
ultrasounds
punto de atención
used by
en inglés
heart
para
doctors.
el tromboembolismo pulmonar masivo
And for the
en las
massive
áreas de
pulmonary
emergencias o en las
thromboembolism in the ICUs
Hoy
or
en
the
día la
emergency
ecografía se
rooms.
encuentra ya situada en
Ultrasounds now
los
are
eslabones de cualquier
some
algoritmo
of the first
que evalúe
steps in
un
every
embolismo pulmonar.
algorithm in order to evaluate
Cada vez ha ido
pulmonary
ascendiendo
embolism.
y ha ido
It is now
superando
one of
a
the
otras
main
pruebas,
techniques
y en
and
este
it is
momento,
well
una vez que
before
se ha tomado
or
la
well
decisión de
ahead,
un paciente
ahead
que
other
está
techniques.
hemodinamicamente estable, bien
So
estable,
if a patient
ya se
is
introduce la ecografía como
hemodynamically stable,
para el diagnóstico de la ecografía,
ultrasounds
de
are
todas
the
formas, hay
first
que tener
step.
claro,
But for the
para el diagnóstico
diagnosis
de la embolia pulmonar, que no es la
of
ecografía,
pulmonary
la técnica de
embolism,
elección.
ultrasound is not the
Indudablemente,
first
sus
choice
niveles de
technique
sensibilidad y especificidad
because the
en numerosos
specificity
trabajos,
and sensitivity
pues, no
levels
superan, por supuesto,
are
a
not
la de una
perfect and
angio-CT
are not
que tiene
better
unos
than the
niveles de
angio-CT
sensibilidad
because
y
the
especificidad
levels
mucho
of
más altos.
specificity and
Pero
sensitivity of the
normalmente
angio-CT
tenemos que
are
utilizar
better.
ecografía cuando los pacientes
But we
no
have to
pueden
use ultrasounds when
acceder a
patients
una
cannot get
ecografía
access
CT,
to an
por lo que sea,
angio-CT
estado hemodinámico,
for whatever
porque
reason,
no se
because of
dispone
their
de ella
hemodynamic
en el centro,
state
etc.
or because it is not
Sin
available.
embargo, para la evaluación diagnóstica, la
But
ecografía
for
puede tener
diagnosis,
cierta utilidad.
ultrasounds can be
La
useful.
evolución que se produce.
The evolution.
Me están diciendo que me pongo unos cascos. Gracias.
Sorry, I need to wear this
Bien, creo que
headset.
tengo dos micrófonos a la vez.
I think I now have two microphones.
Bien. En la evaluación que se produce en
So
la
in the
evolución de los
evolution
tejidos,
of the
lo que vemos es que en
diagnostic
la primera fase se
evaluation of the
produce una
tissues, we see
congestión de
that in the
sangre
first step
en
we
la
see a
circulación
congestion
menor,
of
se
the
cierran
blood
las
of the
pequeñas
minor
ramas vasculares y se
circulation,
produce finalmente una
the
consolidación
small
de origen
vessels
vascular.
are
Todo esto
closed.
es un campo
And
absolutamente
this
adecuado
is,
para la ecografía. Es lo
of
que
course,
le gusta a la
adequate for
ecografía, que haya líquido
ultrasounds
y que
because
ese líquido
ultrasounds
luego
love
se transforme en
this. They
sólido,
love the
en líquidos del
liquids,
aire. Si el aire
and
desaparece,
when
como es
liquids
el caso
become
de un embolismo pulmonar,
solid
pues mejor que
tissues.
mejor para la ecografía. Y
So
eso
it
se
is
refleja
all
en que
better.
estos cambios son
So these tissue
perfectamente
changes
visibles
are
tanto en la
favorable
fase
to
precoz,
use evaluation
donde
both
podemos
at
ver
an
cómo hay
early
imágenes
stage.
hipoecogénicas
We
que
can
están
see
representando
hypoechogenic
esa
images that
congestión
represent the
pulmonar, como en la fase
pulmonary
tardía,
congestion,
donde
and
lo que
also on
vemos
the
son
late stage,
consolidaciones,
the
imágenes
consolidation,
hiperecogénicas o hipoecogénicas
hyper
que
and
nos están indicando
isoechogenic
la evolución
images
hacia
that
un
show us the
Esto
evolution
evidentemente
towards
no
an
puede competir con la
infarctus.
imagen clara,
This
nítida
cannot
de
compete,
un
of course,
angio-CT,
with the
donde estamos
crystal
viendo
clear
incluso
image of an
la imagen
angio-CT.
del vaso
We
ocluido
can
y
even
la
see
zona de
the
infarto, los diferentes vasos ocluidos, etc.
obstructed
Pero sin embargo,
vessel
en
and all
un
the
muy bonito
secondary
trabajo que
vessels.
publicó Kossel
But this
en el año
paper
91,
published by
ya nos
Kossel
decía
in
que
1991
la angiografía
showed
pulmonar
that
puede llegar
pulmonary
muy lejos, tanto como
angiography
los
is well better because it can even show the subsegmental arteries. The echo can only detect problems on the arterials pulmonaris, but when we use a combination of both, we can even see, with the thorax sonography, we can see the segmental arteries. So we combine the ECHO with the thorax sonography, we can get most, we can go very deep. We cannot cover just the segmental, the pulmonary artery, sorry. So you can see here this cross-sectional image of the lung, and we can see the pleural surface, and here we can see this triangle cavity. This is a characteristic of the pulmonary infarctus, and we can see this vortex, which is also a main feature of the infarctus, and a hyperechogenic image, which is a trapped bronchiole. So it is useful for the diagnosis, but the patients, when we see them, they don't have a diagnosis, they have a problem, they have a condition, and they can be asymptomatic, or they can even have a heart arrest. And even if they have a pulmonary embolism, they can be asymptomatic. We've seen this in this paper in 2010. Out of 5,233 patients, 32% of them had a deep venous thrombosis, but they were completely asymptomatic, and they had embolism. So the percentage of these patients that have this massive form of instability and a severe hemodynamic stability is quite large. The PIOPID group collected data for 5 years, and they saw that dyspnea is the main symptom, 73%, and then pleuritic chest pain, and then hemoptysis, but only 13%. And the circulatory collapse was 8%. This is the sign, and this is good for echography, for ultrasound. We've known this for 25 years. Since 1991, we know that ultrasound is good for making decisions in case of respiratory distress or chest pain, hypertension, shock, or cardiac arrest. We know it is unquestionable. So, if the two most common ways of symptoms are favorable for the use of ultrasounds, we can use them. Of course, it is all the more the case when we have tried to get the ultrasounds out of the diagnosis. It can be used by any doctor. The point-of-care ultrasound is now available. It is what we call in Spanish ecografía clínica, clinical ultrasound, point-of-care ultrasound in English. So it facilitates the decision-making in the triage state, and this can be performed by any doctor in the ER, in the ICU. It is accessible by all doctors because the ultrasound systems are available everywhere in hospital. So the main goals of POCUs in PE include the assessment of global cardiac systolic function, the identification of marked right ventricular and left ventricular enlargement, and for the intravascular volume status. And this is all the result of a large paper, a large study published in 2004 that gave as a result the FATE protocol, electroechocardiography for important pathologies. And one of the main pathologies were the changes in the right atrium, massive pulmonary embolism. So we can use the POCUS versus comprehensive echocardiography in pulmonary embolism. This is possible, we know it, but is it safe? Well, 2 papers have been published for the ICU and the emergency room, and they show that it is safe and good. It can also be better than the brain natriuretic peptide or troponin or even the CT without a specific protocol, if it's not an NG-CT. We can see it on table 2 in this paper when there was no type of, there was no alteration on the left, sorry, on the right atrium. No alteration was visible. The sensitivity is 100% and specificity is 99%. And it is well ahead of the other methods. What about the ICU? It is going to be, well, it was published very recently in September 2017 at the Mount Sinai Hospital in New York. It compared POCUS versus the comprehensive echocardiography in PE, both for senior ICU doctors and for junior ones, and they are at the same level. So the sensitivity is very high, very good, close to 100%. Specificity is also very good. So it is a technique that can be very useful, and especially for doctors that are adequately trained. So the role of POCUS in patients with suspected massive pulmonary embolism is to prioritize over other testing, especially if we are assessing the cost effectiveness after differential diagnosis assessments and assist with treatment decisions in conditions with possible complications. Especially this is the case with patients with a circulatory failure or shocks. It is part of the definition of that hemodynamic instability. So we will be looking for an acute card pulmonale, embolus in transit, thrombus entrapped in the valves, and also, of course, the presence of deep vein thrombosis and foci, where there is a focus that is present or that has migrated but left some kind of mark, and also in fibrinolysis. If we have all these indications, we can be happy with the effects or with the symptoms or with the signs identified by the ultrasound. We can diagnose an embolism that can be fatal. If there is just an acute respiratory failure, we cannot say that POCUS is not useful. We can identify the A-line pattern, meaning some horizontal lines and scarce mobility of the pleura. If that has already taken place, because when we see a massive pulmonary embolism, it means that it's been there for 24 hours, throwing emboli to the blood, and in that case we can use the ultrasounds even if there is no embolism that produces instability, and we can use it for therapeutic reasons. And these are my last 3 slides. So this is the ultrasound device. This is an ICU bed, but it can also be a box in the emergency room, and we are assessing a patient that has instability and suspected embolism. So we compare the images, and we see that the pleura has less mobility in the affected area than in the healthy area. This is between the ribs, and this is clearly moving very much. And we see that these A lines, these horizontal reverberation lines, are more frequent and visible in this side. And here in this side we can see some vertical B lines that are not visible in the affected area, because it's interstitial lines, so they're not getting any blood, and that's why we cannot see them. Sometimes we can even identify an infarctus that took place the day before, because it continued to throw little emboli, and we see a drop, and we can see this consolidation, this image of echogenicity, and this triangle that is characteristic, and we can even see some bronchioles. If with the same probe, this is a linear probe that we used for these three images, low resolution. If we put it near the groin, we'll see this thrombus in the femoral vein that is preventing the flow from getting there. It is a very low flow, and it can be the focus, the origin of the embolism. At a cardiovascular level, we can see that the heart is, in the beginning, the ventricle is not functional well, the vein is dilating, and it can create a dysfunction with the McConnell sign. We can see it clearly here, a pathognomonic sign. And we can see the movement that is opposite to the direction of the right ventricle. We see that the left atrium is suffering, the septum is being displaced. We can see a diastolic dysfunction, but then we can see an inversion of the movement of the septum, because the septum is occupying the chamber and is compromising this systolic function. So this right ventricle is not functioning well. The left one is beginning to dysfunctioning, so we can start to work. And in a patient with a cardiac arrest and is now recovering from it, we can see this. The left ventricle is this. It reminds us of a womb, because it is not being sufficiently, it is not receiving enough blood, because it is obstructed. This is a massive pulmonary embolism, a generalized one, and we can see that the circulation on the right side is having a deleterious effect on the left side. This patient has been intervened after a cardiac arrest, and the prognosis is very bad. If we detect it here, it's okay, but if we detect it here, there's not much we can do for the patient. Well, so these are my conclusions. I hope you've seen it very clearly in the images. So I would just conclude by saying that the ultrasound is useful for diagnostic evaluation of pulmonary embolism. It's a facilitator for clinical evaluation of pulmonary embolism. It is highly accurate if we compare it with a comprehensive echocardiography, and it is unquestionable for massive pulmonary embolism. There is no excuse unless we don't have an ultrasound device, of course. Thank you. Muchas gracias. Voy a presentar al siguiente orador, que va a hablar de nuevos horizontes en las terapias de hipertensión arterial pulmonar. Dr. Víctor Moles, de Estados Unidos, es coordinador de la Sociedad y de las directrices de hipertensión pulmonar. Bienvenidos, Dr. Moles.
So first of all, thank you very much to the organizing committee for inviting me. As I said, my name is Victor Moles, and I'm going to be talking to you about the new horizons in pulmonary arterial hypertension. I have no disclosures, although I do want to disclose that I am a cardiologist, not an intensivist. And I want to start by setting up what the definition of pulmonary hypertension is. Since 2013, we've set a definition that pH is a mean PA pressure greater than 25 millimeters of mercury during a resting right heart catheterization, and more specifically to our talk, pulmonary arterial hypertension, or PAH, is defined as pH with a normal pulmonary capillary wedge pressure and a PVR greater than 3 units, PVR being pulmonary vascular resistance. And as you all know, the term pulmonary hypertension is very broad and encompasses a lot of different diseases, and PH has 5 categories. I do want to mention that probably the most common one is group 2 pulmonary hypertension, or the pulmonary hypertension that is due to left heart diseases. And more specifically to our talk, we're going to be talking about PAH, or group 1 PH. That includes idiopathic PAH, heritable PAH, drug and toxin-induced PAH, and PAH associated with connective tissue disorders, HIV infections, portal hypertension, congenital heart disease, and sometimes schistosomiasis. So to begin the presentation, I want to share with you that we started learning about PAH in the early 90s, and this is data from the first National Institute of Health registry, which was the first world registry on this disease, and it included 187 patients, and you will see that the median survival at the time was 2.8 years, meaning in 2.8 years, half of the patients that were diagnosed with pulmonary arterial hypertension were dead. And this is in the setting of not having any medications to treat this condition, and the treatment was merely supportive. So more recently, we've seen a change in this condition. So from the Reveal registry, and what we're seeing, the Reveal registry is a United States-based registry where patients were enrolled from 2006 to 2007. It was a very large registry, included about 5,000 patients. And we started seeing that the median survival is 7 years since the diagnosis. So meaning in 7 years, half of the patients that were diagnosed with PAH would be dead. And that's a dramatic improvement from the time when we had no therapy. I know this is a busy slide, but this is just to show that, and emphasize how much this field has grown. And in the early 90s, we had no medication. Later on, we had epoprostenol, which was the first medication approved for this condition. And as the time goes by, we started seeing a lot of different trials with many medications being approved for this condition. So in 1982, when we started studying PAH with the NIH registry, we had no medications. And in 2017, we have at least 13 FDA-approved medications for this field. So just to go a little bit through the pathophysiology of this disease. So we know that disease begins with pulmonary vasoconstriction. And at the early stages, the PVR and in consequence the pulmonary artery pressures increase. The patient remains asymptomatic and the cardiac output isn't changed. But as the disease progressed, we start seeing smooth muscle hypertrophy, early intimal thickening, and the patient starts developing symptoms as the PVR and the pulmonary pressures continue to rise. In this stage, we may see some mild decrease in cardiac output. So now, in the later stages of this disease, when we never want to find or diagnose our patients, is when we see adventitial and intimal proliferation thrombosis, plexiform lesions, and we think that this is an irreversible stage. So in this stage, the PVR continues to rise, but we start seeing a decrease in pulmonary pressure that is probably due to the failing right ventricle that is not able to mount an adequate cardiac output. So you'll see that in the field of pulmonary hypertension, pulmonary pressures are not something that we follow over time too much because they may mask patients who are deteriorating as, and the fact that if you see somebody who's having worsening symptoms and decreasing pulmonary pressures, you should be very worried about the patient. So these are the 3 main pathways which through pulmonary hypertension is being treated in the current age. So we have the endothelin pathways. We know that endothelin is a very potent vasoconstrictor and it stimulates proliferation. We have two receptors, A and B, and we have endothelin receptors that block either receptor A or A and B. We have the nitric oxide pathway. Nitric oxide stimulates vasodilation and antiproliferation through the action of cyclic GMP. So we traditionally been using phosphodiesterase inhibitors, which what they do is they inhibit the cleavage of cyclic GMP to GMP. We can also administer exogenous nitric oxide, especially in the setting of a critically ill patient. And more recently, we have now guanylate cyclase stimulators, and what they do is they cleavage a GTP to cyclic GMP and produce vasodilation. Now, probably the most important pathway is the prostacyclin pathway. And prostacyclins are known to produce vasodilation and antiproliferation. And they usually act through the IP receptor, which stimulates the increase of cyclic AMP. Now, as I said, we traditionally use analogs of prostacyclins, but more recently we've developed medications that are different to prostacyclins, and they're non-prostanoid IP receptor agonists, and I'll be talking about that in a second. So the landmark studies on pulmonary hypertension, I want you to pay a little bit of attention to the study of 1986. That was a landmark study that included 81 patients, and they used epoprostenol in an open-label trial, randomized to placebo. And this was the first and only study to date that has shown survival benefit in pulmonary arterial hypertension. All of the other studies that have done with prostacyclins have shown an improvement in functional class, but not survival. But if you pay attention, the number of patients including this study is not very large, and that's especially due to the fact that pulmonary arterial hypertension is a very rare disease. It's very difficult to generate studies with large number of patients. So here are more studies about prostacyclin. I want you to pay attention that iloprost, treprostinil, inhaled or orally, they all have about 200 patients including the study. But the latest medication that we added to treat this condition is oral selexipag. It's the Griffin study. And you start seeing that the Griffin study included close to 1,200 patients, which is one of the largest studies in PAH. So this was a double-blinded, placebo-controlled, event-driven morbidity and mortality study. So this is something that the scientific community has been demanding a lot, and in the field we're trying to come up with these studies that not only show improvement in functional capacity, but also target or study hard endpoints like morbidity and mortality. These are some of the endothelin receptor antagonist studies. We have bosentan, ambrisentan, and macitentan. These are all given orally. Macitentan was is the newest medication on the group. It was studied on the Seraphim trial. And again, you started seeing larger number of patients, 750 patients. And again, this is a double-blinded, event-driven morbidity and mortality trial. So the Seraphim study was published in 2013, and it's part of that group of medication studies. It's been coming more recently, and that is answering that demand of finding hard endpoints for this patient. You all know the phosphodiesterase inhibitors, sildenafil and tadalafil. These studies were done earlier on, and they included between 300 and 400 patients, and they were all studying the improvement in functional capacity as measured by 6-minute walk test and mostly symptoms. The riociguat, it's a new medication. It's a relatively new medication, and it's a guanylate cyclase stimulator. The very interesting thing about riociguat, it was not only studied in pulmonary arterial hypertension, but it's the first medication being studied and approved specifically for chronic thromboembolic pulmonary hypertension, which is group 4 PH. So now we do have therapy for patients who have pulmonary hypertension other than group 1. So I want to emphasize that traditionally we'd be treating patients with pulmonary arterial hypertension after they were diagnosed by starting with drug. After that drug, we would follow the patient, and if the patient improved and met some of our objectives, we would stop there, and that patient would be continued with one medication. But if the patient did not meet our goals, so did not improve sufficiently, we would add a second one, and so on and so forth. Now, the paradigm is evolving, and the new paradigm includes using upfront combination therapy. So once the patient is diagnosed with PAH, we would go ahead and start 2 or maybe 3 medication. And there are other fields like oncology and heart failure that have been doing this for a very long time, and they've been having very good results with this approach. So this study is the Ambition trial. The Ambition trial was published in 2015, and studied they used dual upfront combination therapy. And this was a large trial with about 1,000 patients. It was a time to event analysis of the first clinical failure, so it was a morbidity or mortality analysis. And patients were randomized 2-1 to either ambrisentan plus tadalafil, ambrisentan plus placebo, or tadalafil plus placebo. And we see a very clear benefit for the use of combination therapy upfront rather than the traditional approach of sequential combination therapy. So this is a very, a much smaller study. It's a retrospective study that came out from the French group, but tested a very interesting hypothesis, and this may be where our field is heading in the future. This is a study of 18 patients. It was retrospective, as I said, and these were newly diagnosed pulmonary arterial hypertension patients who had a very advanced functional class, or either functional class 4 or late functional class 3, and they had severely advanced hemodynamics. Patients in this study were all started on triple upfront combination therapy with the use of epoprostenol, bosentan, and sildenafil. And as you see in the chart, patients were had very advanced functional class. They could only walk 227 meters. Their cardiac index in average was 1.6, and the PVR in average was 1,700. So what this study showed us that at 4 months and then at follow-up, patients were able to all get back to functional class 1 or 2, and in average they increased their 6-minute walk test from 220 to 500. The cardiac index improved from 1.6 to 3.6, and the PVR dramatically decreased from 1,700 to almost 500. So this may be where our field is heading to, but we will need more studies to confirm this. I want to share some clinical pearls. I think that in the field of PAH, you should have a low threshold to use a right heart cath if the hemodynamics are unclear, especially because the cardiac output, the wedge pressure, and the PVR are not easily obtained from the physical exam. You should not abruptly stop PAH medications, including intravenous and parenteral prostacyclin, even in the setting of the patient being hypotensive. Although it's rare, high output failure can occur with the use of parenteral prostacyclin. It was described by Dr. Rich and Dr. McLaughlin in 1999. And if you have somebody who has PAH who's being treated and is coming with right heart failure, diuresis is probably your right answer. I want to conclude this presentation by saying that pulmonary arterial hypertension is a rare disease, and it has a poor prognosis if it's not treated. The survival, as measured by registry studies, has improved with the use of pulmonary arterial hypertension specific medications. And to date, we have many therapies available to treat this disease. The use of upfront combination therapy is the new paradigm of treatment in PAH. And prostacyclin remain the cornerstone of treatment. I think that it's important to highlight that many patients with this condition die without having used parenteral prostacyclin, which are today the most common medications that we have. So that would be all for me. So thank you very much again for inviting me.
Ventricular derecha en la embolia pulmonar,
right ventricular hypertension,
supongo que las imágenes que
in
muestras de infarto pulmonar
lung embolism.
Capaz que es más sensible buscar la disfunción derecha y bueno, y los picos de corte son indetectibles,
dysfunction
problemas para definir
cutting points
los pacientes que son claros,
problems to define in the clear patients there is no doubt, but what are the cutting points and the advantages of these cutting points in the presence of pulmonary lung embolus? Well, I am a very faithful follower of the FATE sequence. I think it gives us very good information. It allows us to disregard the presence of pericardial problems. It gives a very good idea of the situation of patients, and it is an approach that gives patients a very good results, especially when they are submitted to mechanical ventilation, because the lung will not be put in between, and therefore we will have a very good visibility. And then, the parameters are the ones that are described in the bibliographic literature. The ratio between the right and the left ventricles, the position of the wall. I practice a very qualitative rather than quantitative clinical treatment. I think that for the decision-making process in our classifications, with just at a glance we can classify the hyperdynamic, very reduced function or slightly reduced function. We know with just a little change of color, we know whether there is a tricuspid dysfunction, and therefore the qualitative parameters, whether the left and the right ventricles, I don't see them as very useful in the handling of our patients. Yeah, wave, these things can be used out of intensive therapy. So you don't give an importance to that. Is a relationship? Yes, no, I'm not going to measure the CT when I'm handling embolus. I think I should not lose time in that.
Hello.
Sí.
Hola. Hello.
No sé si alguien tiene alguna otra pregunta. Para Víctor Moles tengo otra pregunta, pero no sé, no quiero acaparar.
I have another question for Victor Moles.
No sé si Manuel Garay o Aurelio Rodríguez.
I don't know whether Manuel Garay or Aurelio Rodríguez can answer to this. One question for Jesús Álvarez, please.
Sí, doctor Álvarez, Víctor Moles. Una pregunta con respecto
I have a question
creo que mito de la hipertensión pulmonar en la embolia
about pulmonary or lung hypertension in acute embolia. How do you interpret the lung pressures? Do you look for high lung pressures in the case of serious embolus, or if you're not observing claudicating ventricle? Well, this is in line line with the answer that I gave before. I think that qualitative clinical therapies are the most important. We, of course, tend to have quantitative levels that we can put on a table, but in the daily clinical practice, when we have to assess our client, I think it is more technical. Technique is more important to get a better visualization in a certain window, so as to see the good movement of the ventricle. As we saw in the ventricle that was failing, and in the next slide, it had already been failed. I mean, it was already failing. I think these images tell much more than any CT or any other TAPSE or any type of other assessment. Thank you.
No sé, estoy de acuerdo con lo que tú dices.
I agree with what you say.
En la práctica clínica,
in the clinical practice, one has to be expeditative. You cannot really measure things because some windows are difficult to be measured, and I absolutely agree with you. The relationship of the area and the diameters is what defines the whole situation. After the presence of NOx, the time at the peak, etc. Well, we had time to do that, to do all that. Then the patient is not so unstable, and then he would go to the other branch of the algorithm because the cardiologist should perform an appropriate ultrasound or a scanner, and therefore we can see the function and how the function is really doing. So if we have time, of course, provided we have some time to do that. There is another question. The question to Dr. Moles. Dr. Moles, are you there? Yes. I agree with what you were saying about the upfront combined treatment at the beginning, at the onset, and this is what the latest guidelines are saying, and this is what we were doing with the latest works and the clinical trials. But in the daily clinical practice, given our drugs, what would you recommend to do monotherapy and then add other treatments, or would you, from the start, would you apply a combined treatment? Well, I perform all my training in the US with the Dr. Malay McLaughlin, and our reality was a very different one to today's reality. I am now working in Argentina. In the US, a patient has pulmonary arterial hypertension will receive an upfront combined therapy, and the insurance companies, the medical insurance companies, do not have any problem with that. But in a case of a patient with functional type 1, we can think of the cost, the social cost, the economic impact of that patient, and we must think that he's a low-risk patient because he hasn't got so many symptoms. But reality in Argentina is a bit different. The medical insurance companies only cover a percentage of the costs of the drugs, and therefore if the drugs are very expensive,